For waiting. I'm Dr. Michelle Quinn, certified audiologist, here to talk to you for the next hour or so about hearing loss and hearing aids, specifically in the geriatric population. And I graduated from the University of Washington in 2006 with a clinical doctorate in audiology, known as an AUD. And then I went out and worked in New Zealand for 5 years, fitting adults with hearing aids and doing hearing testing. And then came back, and I've been with UW Medicine for the last 7 years, mainly based out of Harborview. And this year I started doing Harborview full time. So that is now my permanent home. And I'm absolutely delighted to come and speak with you guys about my topic of expertise. We are touching on a lot of different topics in this lecture, and I know some people are going to want to go more in depth on certain areas. Save your questions for the Q&A. I'm going to leave about 15-20 minutes at the end, and we can dive into some of those areas a little bit more. And I'll point out some of those as we go along through the lecture today. Okay, we've already started. Have a seat. You are off the hook. It's okay. It's okay. All right. Yes, we just did introductions. Okay. Okay, goals for today. Let's get the mouse off of there. All right. So this is a very practical based lecture, and this kind of comes from being a clinical audiologist and not a research audiologist. So if you're looking for lots of graphs and numbers, I'm going to disappoint you a little bit. But if you're looking for skills that are going to be really practical as you interact with patients and work in clinic or hospital settings, this is the lecture for you. So at the end of this presentation, participants will be able to, goal number 1 that I want you to achieve, discuss with patients the importance of having a hearing screening or a hearing test as part of a routine healthcare maintenance plan as a geriatric person, okay? And so we're going to talk about when is it appropriate to start testing hearing, what are some ways that we check hearing, why is that important, what are age norms, things like that. Okay, goal number 2, I want you to be able to identify and implement in clinic ways to better communicate with your patients, and specifically patients with hearing loss, right? There's 2 different meanings to this. One is actual practical communication skills, how to better talk with somebody who maybe has a hearing impairment. The other is communicating information. You know, if we're going to start having a conversation about how you feel about hearing aids and you don't know anything about hearing aids, you're going to need some knowledge to be able to kind of fill in that gap and have that conversation, at least to decide if you're going to refer or not and things like that. So we're going to go over that. Last goal here, identify and list at least 3 factors that play into successful hearing aid use. The reason I've put this in is there's a lot of people that complain about hearing aids, and there's a lot of people that have heard or ran into very negative experiences, and they say, why should I go ahead and help my hearing? Everybody I know hates their hearing aids. And the issue I have is a lot of problems with hearing aids can be addressed in clinic, and they can be improved through clinical intervention. And a lot of people who wear hearing aids don't know this, that they don't realize that a lot of the issues that come up can be addressed. So I'm going to talk about what goes into successful hearing aid use and maybe identify, you know, some of those things that if somebody's complaining about, you say, look, go see your audiologist. They'll be able to do something about this, okay? And then as a bonus, I've added this in. I was sharing with those that are here present in our classroom before we started. I was making this presentation and I realized if you are working in the geriatric population, especially if you are nursing, the likelihood that you're going to touch somebody's hearing aid at some point in your career is kind of high, especially if you're doing inpatient. But outpatient clinical, you might have to deal with hearing aids. You know, maybe they have to be taken off for a procedure or something like that. Or you might have to help somebody troubleshoot, whether you're in a clinic, hospital, or home setting. And just some really basic information about hearing devices could really help you out. So things like, how do I tell right from left? How do I turn this on and off? How do I make sure I have the right battery? So that's bonus content we'll put on the end before the Q&A. Okay? All right, outline. So to achieve these goals, this is the content we're going to go through. I've got to give you a little bit of context. And we're going to start out with the basics. which is a review of your ear and hearing and how we test hearing, just to give you that context. And then we're going to dive into what does age-related hearing loss look like specifically, and look at some of those age norms. Then we're going to go into the effects of hearing loss on the elderly and switch kind of from this objective measurement of hearing to subjectively, what do we hear patients say in clinic? How is this actually impacting lifestyle, things like that. And then we're going to go looking at the primary care setting. So if we're going to have conversations about hearing and hearing loss in the clinic or in the care setting that you have, you know, what are some questions you might want to be asking? What are some nice general tools that are easy to use without having to feel like you're trained in this area, right? And then we'll switch into helping hearing and talking about hearing aids or rehabilitation, what makes a good hearing aid fitting. And I did stick in generic over-the-counter amplifiers. This comes up all the time. It's a hot topic. It's only going to become more prevalent over time. So I did want to take at least one slide and address generic over-the-counter amplifiers. And then the basic care and handling of hearing aids is that bonus content at the end. So we've got to get cracking here. All right, this is basic context. Hopefully this is review, but I am putting it in here for anybody who doesn't already know how your ear works. And if you do already know how your ear works, this is the spiel I give my patients when I explain how you hear. So you might want to hear kind of how I talk about the hearing test. So this is a slice through your ear, and you've got the first part's your outer ear that sticks out. And if you don't know, that's the pinna is the medical name or term for part of the ear that hangs off your head. And I call this the collector. That's what this part of the ear is doing. It's just collecting sound. There is a reason our ear is shaped the way it is. It's specifically designed to collect and amplify pitches important for speech, hearing, and the clarity of speech. Okay, and then this is my sound wave, and the sound wave goes through the ear canal. And the first thing it hits is the eardrum. This is the green part here that I've just highlighted. And that eardrum starts vibrating, and it sets into motion these three little bones right here with the arrows. That part is all vibrating. It's a mechanical vibratory system. It's called the middle ear. And all this is doing is it's amplifying. It's turning up the volume. So if you have a hearing loss in this part of the ear, it's just like taking the volume dial and turning everything down. All right, once the sound has been amplified, it's going to go to this little swirly part. When you look at a picture of the ear, it's the part that looks like a snail. This is the cochlea or inner ear. It's the actual organ of hearing. So I describe this as the converter or the changeover mechanism. So our sound wave goes into the ear, and the cochlea is changing it, right? Triangle for change, into electricity. And it's because that sound's going to go up the 8th nerve and right into your brain. Okay, so the ear, when we're testing hearing, we're testing the ear mechanism here. There is the rest of the story, and this is very important in the geriatric population, is your neurological state. Okay, so I've got a slide on what's happening once that sound gets converted and sent up the 8th nerve. So here, the rest of the story is, first of all, you have the auditory cortex, which is this purple spot here in the temporal lobe. That is the part that lights up and says, incoming, I've got sound. Bam, the brain has received sound. And there's two things that have to happen after the brain receives the sound. The first one is we've got to identify what that sound is. So this is where we use our memory center, the hippocampus. We're literally labeling sounds, like that's the dog barking, that's the TV playing, that's someone outside. So the memory center of our brain, the hippocampus, is identifying or labeling sounds for us, right? And then the last part is we have to figure out how are we going to react to this sound. So the example I like to give is if I'm sitting on the couch and I've ordered pizza for dinner and I hear the doorbell ring, I'm really excited. That's telling me pizza's being delivered, it's dinner time. If it's 3 a.m. and I'm lying in bed and my doorbell rings, I'm gonna have a very different reaction. And that's an example of amygdala, your reaction to sound. So these are the three basic things that are happening neurologically, right? We've got to receive that sound, identify that sound, and then how are we going to react to that sound? I'm not going to go any more in depth than this, but I think that's important to keep in mind that the brain is connected to the ear and those two do affect each other. Okay. What happens when we test hearing? So we're just testing the peripheral part of the ear. There are batteries of tests that are trying to get at the neurological hearing side of things. Those aren't done as often. I'm going to focus on what the standard hearing test battery is. If you referred somebody to get a hearing test, or if you scheduled yourself to get a hearing test, this is what would happen, okay? So first thing, otoscopy. I'm going to look in your ear canal, make sure that that outer ear is not blocked with earwax or that there's something funky looking down there. I want to make sure that it physically looks okay. For my nursing students, the more ears you can look in, the better. Every opportunity you have to look in an ear, look in an ear. There's a wide variety of kind of shapes and curviness to ears, and so the more you look at them, the better. Then we do tympanometry, and that produces what's called the tympanogram, and that is testing the movement of the tympanic membrane or the eardrum. And if you go rifling through audiology records, eventually you're going to find something that hopefully has a little mountain shape on it. This is the tympanogram. And what it is it's one movement of the eardrum. So your eardrum's like a musical drum. It's going to sit and vibrate up and down. This is measuring one movement up and one movement down, and that's how we get a mountain shape on the tympanogram. Like most things in medicine, if you have a flat line, that is bad. That's the other outcome to this, okay? So we're looking for nice mountain peaks and not pancakes, as we tell the kiddos. Okay, so that's testing. Otoscopy is looking at the outer ear. Tympanometry is giving us information about the eardrum and the middle ear system. And then we're gonna go on to the inner ear. Okay, that's the middle ear within tympanogram. Okay, to test the status of the cochlea or organ of hearing, we're going to map out hearing on an audiogram. And what we're mapping out is how quietly you can hear. I want to know where you can just pick up the sound. Okay, when we talk about hearing and hearing loss, we talk about threshold, or where you can just hear. So that's what's going to be mapped out. And along the top, you're going to have frequency, or layman's terms, pitch. The way I remember this and what I tell my patients is, if you're familiar with a piano keyboard, the piano is laid out from bass up to treble, okay? That is the same scale we're using on this graph, bass to treble. And this becomes important because most people lose their treble hearing first, and you'll see this on the H norms, okay? And then along our other axis is loudness, right? How loud do I have to make this sound for you to hear it? So I've got very soft or quiet sounds at the top of the graph, very loud sounds at the bottom of the graph. This is measured in dBHL. It is a different scale than SPL if you're into physics at all, okay? It is still a logarithmic decibel scale. All right, and so what we get is a graph, and these little dots are where the person could hear the sound. So for each pitch, I go, okay, how loud do I have to make this for you to hear it? We have a bracketing procedure, and then we're marking where they're just picking it up, okay? So that's how you get the hearing test record, the objective measurement. All right, we do this two ways. First of all, we do the beep test, as I call it, and tell my patients, through a pair of headphones, and that's testing the whole entire ear system. And then I go back and I do the same exact test, but this time I've got a headband with a little box that sits on the temporal bone and vibrates the temporal bone. That is directly stimulating the cochlea or the inner ear. So I now have the same test through two different methods. This helps me sort out where in the ear the hearing loss is happening. So I'm going to give you an example of what this looks like on the graph. Okay, so this hearing test here, the first line with the dots is the first hearing test where I'm testing the overall ear through the headphones. And this is showing a flat, mild hearing loss. And then I do the second beep test, and I'm bypassing the outer ear and middle ear. I'm just testing the inner ear with the box sitting on the temporal bone and vibrating. And all of a sudden the hearing pops up and it becomes really good. And I go, aha, all that hearing loss right there, there's something in the middle ear or outer ear that's blocking the hearing. This is important to know because we call it conductive hearing loss. Usually we're looking at medical intervention first to see if this can be resolved before looking at hearing aids. So things like, I have an ear infection, my ear is blocked up with fluid, it's going to create this type of hearing loss. Or I had a really good hit to the ear and it actually dislocated those little bones. you're going to get this type of hearing loss. ENT can go in and fix that, stuff like that, okay? So again, mechanical system in the middle ear, conductive hearing loss. Now, what we're interested in for our population is what we call sensory neural hearing loss. So this is the cochlea, the inner ear, and beyond. And what we get on the graph is a first hearing test. Right here, this is showing a flat, moderate hearing loss. And then I do the second set of beeps through that headband with the piece behind the ear, and it's the exact same. The two match up together. That is sensory neural hearing loss. It's important to know that because right now there's no fix for this. There's no medical, like, just go and get yourself fixed. We're looking at hearing aids, okay? So that's the two main classes of hearing loss. You can have both types. We call that mixed, surprise. But most of what I'm talking about when I say hearing loss today is sensory neural hearing loss, and we're looking at hearing aids to help that, okay? So that's the context around the objective measurement of hearing loss and that background on how we test hearing objectively, okay? All right, the other thing we do as part of that beep test is speech testing, because speech is a lot more realistic than listening to beeps. And really what I want to know is if I turn the volume up so you can hear it, I'm overcoming whatever hearing loss you have, it's loud enough, is it clear or not? And so I present at a loud level, it's audible, and I'm saying, look, can you just repeat the words back? And I'm going to start saying a list of words or have a recording of a list of words. And we see how many you can get or repeat back, okay? And this does a few things. One, this is taking away visual cues, taking away context cues, just seeing what the ear's doing. And you get a percentage, right? How many out of 100 can you repeat back? You get 100%. This is important to know because it can start affecting how well somebody does with hearing aids. It's not a direct predictor, but it is important when we talk about successful hearing aid use. And I use a little analogy here to the radio. Whoop, go back. Radio analogy. Okay, radio analogy. If you have old school radio that you're tuning in and you're not quite tuned into a station and it's really staticky, right? Like you hear every third or fourth word coming through. Okay, I don't care how loud you turn your volume dial, it's still really staticky. There's a lot of what I call distortion going on. Some hearing losses are like that it doesn't matter how loud you go with your hearing aids, it's really distorted. Sometimes I joke that it kind of sounds like the adults on Charlie Brown, right? Like it's just not clear. And if you've got high distortion in your hearing loss, it's very tricky to use hearing aids. You're going to either need extra help or you're going to need to keep watching the person who's talking to get the visual cues or other augmentation. It's just important to know that. Now, the good thing is this distortion or lack of clarity in hearing loss is pretty rare. It's not super, super common. But it is good to know about. And it's an important reason why we check words when we check hearing, to look for, if I make it loud enough, can you hear it? Okay, we're gonna look at norms here. Let me go back. All right, this is age norms. We have a graph for men, a graph for women. And good hearing's at the top of the graph. I'm gonna say this several times throughout this lecture, but we've got 25 and above is the box of good hearing or normal hearing. And each line on these graphs is an age average. We have 30 years old, 50 years old, 70 years old, and 85 years old. And there's a few things I want to point out from this data as the hearing changes. Okay, first of all, we start testing for age-related hearing loss around 65 years old. And you can see that between that 50 and 70 line is where we start dipping down outside that box of good hearing. And so this is where we go, all right, it's good to get a hearing test on file. And there's several reasons I'll go into that for. But occasionally I'll have somebody come into clinic and they're like, I'm 40, I think I'm having age-related hearing loss. Like, I say, you may be having hearing loss, but you're not having age-related hearing loss, okay? So 65, that's where that number comes from for age, is from these averages or norms on age-related hearing loss. Now, another thing I want to point out is we start losing our hearing in the high pitches first. And also the hearing test at 65, even if you have good hearing, it's going to be a baseline. So I get asked all the time, You know, how long do I have until I'm completely deaf is basically what people ask me after a hearing test. And I say, look, we don't have a good tool. I'm going to go all Professor Trelawney on you. Like, I'll get out my crystal ball. We just don't have a good tool to predict what your hearing is going to do over time in the future. But if we collect multiple hearing tests over time, we then have some data points, right? And we can start graphing out, is your hearing staying the same or is it getting worse? If it's getting worse, kind of how quickly? And that becomes very important. So the age 65 really becomes a baseline. That if you wait until you have a major change in hearing or a major hearing loss, I have nothing to compare it to in the past. So that's where that number comes from and why we encourage some type of record of hearing, maybe a little earlier in the picture than you would think for referring for hearing loss. Okay, this is a slide that I have up in my office. Eyes checked, teeth checked, hearing checked, and this idea that you know, we routinely go in and check other parts of our body, but hearing often gets neglected. So we do recommend annual hearing tests for people with hearing loss just for that data tracking purposes. Sometimes if there's a very slow moving hearing loss, we'll push that out to 2 years or a year and a half, just depending on what's going on. Okay. Presbycusis is a very gradual progressive loss. This is just a quick case study I pulled. I actually saw this person today. This is an old hearing test from 2011, and then I tested them last month, which is 2019. And this is a very elderly person, so 87 in 2011, 95 currently. And you might initially look at these two graphs and go, okay, that looks the same. That looks like two big, you know, kind of lines going down the graph there. But once you start comparing point to point, there is a significant difference. If this person's a hearing aid wearer and they got their hearing aids in 2011 and they've never had them turned up or adjusted, seeing me in 2019, they're going to be struggling. And I'll say, look, you need your hearing aids turned up. And then that's usually something I do as part of my clinical services. So the idea that hearing changes very gradually, that year to year we might not notice or think we have a difference. And that's another reason to objectively record what's going on. Okay, this is the audiogram of familiar sounds. The reason I popped this up is we see this curving hearing loss. This is the pattern of presbycusis. And it means we lose the treble hearing first. And it's literally a byproduct of how our ear is designed and built. And it's literally wear and tear. And what I want to point out is on the speech sounds on here, when you're missing the high pitch, especially the soft high pitch sounds, it's the consonants that start to go first. Things like S and SH and T and TH, those sounds start disappearing. And the reason this is problematic is consonants are at the beginning and ends of our words, and they tend to define or give clarity to our words. So for example, mat, math, and map, if you're having a hard time hearing that last sound and you don't have any other context, you're going to start guessing, and it can be very difficult. All right, we're going to switch a little bit from the objective to the subjective. I'm really squashing my urge to ask for questions because I'm so programmed to do that both in clinic and teaching. So we're going to wait for the questions for Q&A, and we're going to move on to subjective. Okay, great. Yeah. The questions will be moderated. Okay. So subjectively, how do we present in clinic? I've got this huge list of things I hear all the time. My hearing's not as good as it used to be. It's not bad, but it's not as good as it used to be. I know I'm not as sharp as it used to be. I'm missing or mixing words. And again, that goes to losing those consonants first. I can hear you, but I can't understand you. So again, I know you're talking, but I just can't quite make it out unless you're facing me or I have visual cues or whatever. I'm having trouble hearing in groups. This is massive. As soon as you start getting multiple people, if somebody's using visual cues to hear, it's very hard to track, you know, where is the next person talking and to key into that. If I can't see you, then I can't hear you. Again, that's compensating with visual cues. I'm having trouble hearing when there's lots of other noise around. For example, dining areas, especially in kind of retirement places, or just background noise in general. This is the hardest area for our ears to hear in. It's the most complex environment, is to try to hear when there's other sound going on. There are many factors that play into our ability to do that. And so this is the most common complaint we get, or what comes up first when you start to lose your hearing, is the hardest. You notice that you have trouble in the hardest situation to hear, and it's not hearing in quiet, it's hearing in background noise. Okay, I'm having trouble hearing if someone's far away, so across the room, in another room, or in a lecture meeting setting. That's very common. Or if somebody's very soft-spoken. I'm tired of asking for repeats. I say what a lot. I had a patient who came in and he said, my friends call me Mr. Huh, because he's always asking for repeats. The TV is up louder than others prefer. This is also a very common kind of first noticing a hearing loss symptom that I hear a lot, that, I have the TV up louder than my wife prefers, or whatever. Okay. Little comics throughout here. I think you need a hearing test. Why the heck do I need a hairy chest? So it's often family members and people closest to the person with a hearing loss that are going to be impacted and notice the hearing loss before the actual individual. And that seems a little counterintuitive. And part of it is because we lose our hearing so gradually. And I tell patients this all the time. I said, look, if you had perfect hearing and then you came into my office with this type of hearing loss and it happened overnight, you would be in the ED asking to be fixed. You would know that this is a huge problem. But because it's so gradual, we just acclimatize as it comes on. All right. You may have seen this progression before. I'm going to apply it to hearing loss. But hearing loss, there's nothing to really indicate there's something wrong until you start interacting with that person. But this idea of, it's almost perfect, it's not a big problem. It's a problem, but I can live with it. I'm not happy with this situation. And then we escalate up again. This is a major problem. And then I need a solution now, or as I say, yesterday. And unfortunately, this is a horrible statistic, but we're currently at 7 years between I know I have a hearing loss and I'm getting hearing aids. That is absolutely atrocious and massive. And I think we can do a lot to be better in that area. And I think it really starts with kind of this grassroots education of people that are having conversations, especially in the geriatric population, whether that's nursing, nurse practitioners, primary care providers. We have some social work here, just saying, hey, you might want to get your hearing tested, or you don't have to live with a hearing loss. Might help you out a little bit. Okay, Adventures of a Hard of Hearing Dad. The son says, I'm fine, Dad. How are you today? No son of mine is getting married in an arcade. Against this idea, hearing loss really does impact all relationships. You just ask with somebody that lives with a person with significant hearing loss who won't wear their hearing aids, and you'll know how frustrating this is. And so I see this all the time in clinic. Untreated hearing loss can have a cascade effect impacting mental health, especially with isolation and depression. This is well documented. If you're interested in this, there's a ton of research in this area. It's been a very hot topic lately. The hearing aid manufacturers really like this area because it's promoting, get better hearing, prevent these things or whatever. So I'm not going to spend a lot of time on that. I do have on here, if you're doing any type of cognitive function assessments, and even if it's a really basic, like dementia screening or something like that, make sure the person can hear you okay. I see this all the time. Like, we're referring somebody that's having their initial neurological workup because we're not sure how much a hearing loss is contributing to either mishearing or miscommunicating, and we really want to rule that out before we make a definitive neurological diagnosis. And I usually say, thank you very much, because this person does have a significant hearing loss, and this is playing into what's going on. So that's very, very important. I think that as part of that silent sickness, this gets missed a lot, especially in the geriatric population. Okay, talking to and with people with hearing loss, a little practical tips for in clinic or wherever else you end up. Slowing your rate of speech is going to be way more beneficial than raising the level of your voice. So most people go, oh, you didn't hear me, I need to talk louder. I say, no. You need to talk slower. So a little cartoon to illustrate this. I don't know how many of you are familiar with Zitz cartoon. This is Jeremy and his mother. And he's going, blah, 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 blah. And she's like, what? And he says it again. He says, Jeremy, I can't understand a word that you're saying. Can you just talk slower? And he says, well, can't you just listen faster? And I think we often play this out with people with hearing loss. Somebody once told me fast speech is like fine print, to use a little bit of a visual analogy, which was kind of an interesting description to me. Okay, so talking at a slower rate is more helpful than talking at a louder level. All right, this is again practical things, especially for our nurses and medical assistants and even care providers. Unfortunately, with our technology in this day and time, more often than not, we're looking at a computer screen and entering information or checking information. That is horrible for somebody with a hearing loss. And just because somebody has hearing aids does not mean they do not need to look at you when speaking. Visual information is always helpful. And so I say, look, please do not talk to your computer screen. Make sure you're watching, looking at the person you're talking to. This little meme, I can't hear you, so I'll just laugh and hope it wasn't a question. Okay, I see this a lot in my elderly population, especially with hearing loss, this kind of bluffing, right? Have you ever maybe been around somebody that just kind of smiles and nods to everything? It's a little bit of a red flag. And sometimes hearing loss can be the reason for that. I've also stuck this up here because if hearing aids are off, then don't ask questions, don't talk. And so you might have to take hearing aids off for a procedure, or if you're inpatient, you might have them off for resting or something like that. Don't just come in and start talking. And I tell my students this all the time. They're like, we're going to test your hearing. And so they take the hearing aids off and then they give the instructions for the hearing test. And I said, they can't hear you. Don't do that. Got to wait and give those instructions first, then take the hearing aids off. Okay. Also, this is a good rule of thumb for pretty much anybody, providing information in writing, right? Where I say, look, I've got this written out. I'll print this out for you so that you can take it home and kind of read it later or remember. And this is getting back to the brain is connected to the ear, and a lot of neurological overlay in the geriatric population. Just providing things in writing is always a good idea. But that helps if you have a hearing loss, especially severe hearing loss. Okay, this is my slide that I put in for hearing loss and dementia and Alzheimer's. It's a hot topic, especially in the research field. What we have here are the Lancet 2017 risk factors. If you haven't seen this before, it's pretty interesting. There's a visualization of over time, meaning the lifespan on the left there, and then the same factors that are the colors in that visualization are in this table where you can actually read and see what they are. And it's this idea of, are there factors over the span of the life that if we intervene or change these or even have them, does that change our risk for dementia and Alzheimer's? And the context on this, I know this is really hard to read for you, but I believe it's 36%. All these factors add up to 36% that we can kind of have control over, so to speak, in a really loose way. And then the rest, 60 some odd percent is like our genetics and things that we can't change at this point, right? And what I want to point out on here is we got very excited in audiology in that hearing loss is a pretty recent addition to this list of factors that can kind of change a little bit. And basically it's a 9% reduced risk if you have intervention for your hearing loss in middle age towards dementia, Alzheimer's. And that's, to me, that's a massive statistic. And I think it's really encouraging to try to break down this idea of, shouldn't I wait until I have like a really big hearing loss? And I those purple bars of like, I needed a solution yesterday type thing, we're still in that stigma. And I think research like this is really helping to break down some of that stigma and say, actually, the earlier you get into the game, the better. And a lot of it is cognitive neurological reasons. Okay, so that's the nod there. Okay, addressing hearing loss in clinic. So some practical things if you're seeing patients, and you can apply this to if you're doing home care or residential care as well. But I just come from a clinical background, so I kind of put generic primary care up here. I love this. As for your hearing test, you can hear neither diddly nor squat. So also the way to general practitioner, looking in the ears, it could be anything. So, right, when we ask the question, do you think you have a hearing loss? This is a very wide question. It's a very general question. And I want to put forth the argument that if you're dealing with the geriatric population, it's not so much a question of, do I have a hearing loss or not? It's how much of a hearing loss, how is this impacting you, and how ready do you feel to get into hearing aids? So I've got a few slides to kind of breeze through about that. I do want to give you this tool, and this is a little more of a reference. If you're interested in this, you can go back into these slides. This is a great study from JWWA. It's a decade old, but they basically asked folks, just rate your hearing on a scale of 1 to 10, with 1 being very poor hearing, 10 being really good hearing. Where do you think you're at today? And this is a great task because we're all really familiar with this, right? Like, oh, you're having pain. Can you rate your pain on a scale of 1 to 10, right? Same thing with hearing loss. And what we saw in the summary on this study, and I don't say we in that I participated in this, but as a field, is if somebody rated their hearing very poor, there was a very high correlation with going ahead and getting hearing aids and getting some help or some intervention. And then there was what you would expect, a little bit of a gray area where these people weren't sure and they needed some more information to make that decision. And then if somebody felt their hearing was really good, 8, 9, or 10, then there was a high correlation of obviously not going ahead with hearing devices or helping their hearing. And so this turned out to be a very handy tool to kind of help sort out referrals. Like, okay, if somebody's rating their hearing on 1 to 5, say go see an audiologist, just get a hearing test and have a chat with them. That there's a likelihood that there's some need there. So this is nice because it's just one question you have to ask in clinic. Rate your hearing on a scale of 1 to 10. Okay, so it's a good tool. Sometimes I love this elderly couple are shouting at each other, we can't put it off any longer, we must book hearing tests. And again, this idea of asking the right questions. By the way, I love it when couples come into clinic. Is my favorite thing ever, his and her hearing tests back to back. Again, the majority of the geriatric population is already going to have a hearing loss. And so we need to have a conversation about how is this impacting your life? How ready do you feel for hearing aids? So self-perception of hearing loss impact on lifestyle. Again, this is just a tool and kind of a reference slide for you. If it's something you find interesting, you can go back and pick this up. It's called the Hearing Handicap Inventory. It's the screening version, which is 10 questions instead of 25. And it's the elderly version. So the questions about work and hearing work colleagues and stuff like that have been modified. And this is a very standard questionnaire format in that it's yes, no, or sometimes answers. This is easily put into intake paperwork or something that the patient can do before or after they come in. And it's looking at impact of hearing loss on lifestyle. It's that subjective kind of measurement, but putting it into a number. And I use this a lot for documentation purposes, especially if we're getting into situations with a lot of denial, where there's a big mismatch between I'm measuring objectively this hearing loss, but when you answer these questions of how it's impacting your lifestyle, it's an abnormally low number. And that can be very tricky. Folks that are in denial, a lot of counseling around that issue is needed. So the Hearing Handicap Inventory, screening version for the elderly, 10 questions. And then it's just scoring of yes or 4 points, sometimes 2.0 for no, and a total score of 40. And then the bar is 10. So anything above 10 is significant impact of hearing loss on lifestyle. Anything below 10 is basically, I don't have a problem. Why would I need a fix? I don't have a problem. And so that's a big red flag. And it's good for me to know about that in clinic. Again, that goes back to cases where we kind of get into some denial. Okay, that's kind of reference. Now, this is an important slide. There's no correlation between the objective and subjective. So you would think, the bigger the hearing loss, the more that person's going to be willing to go out and get hearing aids. Not necessarily true. And this goes back to lifestyle and your hearing needs. So I could have somebody that has a big hearing loss. It's come on really slowly. They live by themselves. They're not getting other people telling them, hey, you might have a hearing loss. And they're going, I'm fine. I sit around and I read books all day by myself, which is not realistic socially, but hey, I'm sure there are people out there that do that. And whereas the flip side of that coin is I could have somebody with a very mild hearing loss where I'm like, oh, you just got a little bit of hearing loss here. We'll just watch this. And they're going, I'm freaking out because I'm a musician and I rely on my hearing and I really need some type of help for this. And I go, ooh, totally different scenario. And so then we have a conversation about that. So this variable of lifestyle and hearing needs is really important and can kind of make or break your conversation about impact of hearing loss on lifestyle. Okay, so there's no magic line on the hearing test that's like, oh, you're over the line, get hearing aids. And a lot of people want to hear that. They want to hear, you know, like that type of hard and fast rule, and it doesn't exist. Okay, there is a strong correlation between your self-perception of hearing loss and your readiness for hearing aids. This is the #1 factor for successful hearing aid use. So remember, one of our goals is, what are 3 factors for successful hearing aid use? The #1 factor is personal motivation. And it's because this is an extra piece of gear that's electronic that you're going to integrate into wearing every day, and you're going to reteach your brain how to hear through it. And you've got to kind of be ready to commit to that a little bit. Also, getting set up with a hearing aid involves several clinical appointments, and the logistics of being able to kind of commit to that and to get in and have somebody help you do that is also, you got to have some personal motivation. And that's why it's very hard to fit hearing aids to somebody who is in denial, and the family are the ones that are really pushing and saying, just fit mom or just fit dad with hearing aids. And I'm like, we can't just do that. Like, we've got to have a discussion about being willing to wear and use that gear. Otherwise, it just ends up in the drawer. Okay, screening audiometers. So again, this is wrapping up the section on kind of in-clinic tools that you can use to kind of start to get an idea of where somebody's at on the hearing loss side of things. So we had the rate your hearing on a scale of 1 to 10. We've had the hearing handicap inventory, is that subjective impact of hearing loss on lifestyle. This is the objective, actually measuring hearing. And screening audiometers are great. The audiologists love screening audiometers. They're easy to use. Nursing can do this. Medical assistants can do this. Primary care can do this. These devices are specifically built and designed for screening. Right ear, left ear, put the headphones on. I'm going to play a beep. Just raise your hand or tell me when you hear the beep. And what we do is we do the 4 most important pitches for speech clarity and understanding, and we do them at a soft, medium, and loud level, and I'll show you that on the next slide. But this equipment can be expensive. It's about $1,000 to buy a good screening audiometer, but they're very worth their weight in gold, at least from my viewpoint. And our clinics at Harborview, we have these in the pediatric clinic and adult medicine clinic and in the senior care clinic as well. Okay, so this is, if you're going to use a screening audiometer, you're going to have your results on a little grid kind of like this, and it's a very simplified audiogram. So we've got 4 pitches that are the most important for speech clarity and understanding at the top. And then I've got a soft and a medium and a loud level that I'm going to play these at. And these literally correspond to soft speech, medium speech, and somebody yelling loud speech. And I'm starting to map out, which ones can you hear for right and left ears. And it's just this very basic screen. The pattern that you see up here is, again, presbycusis, or losing the high-pitched hearing first, okay? All right, we're going to switch gears again. So we've gone through the audiogram, the anatomy of hearing, impact of hearing loss on lifestyle, very practical kind of conversational clinical tools you can use. We're now going to get into the hearing aid stuff. So this is going to be a bit of a whirlwind tour here, and some of these I think I'm going to either skip or zoom through just given on time, but we'll see how we go. Okay, I love this. So I finally got hearing aids. Yes, I realized it was silly to think they'd make me stand out. And I just love this. This is like the Seattle comic, right? You good old espresso coffee shop here. So asking about how do you feel about wearing hearing aids, that's going to be more telling than do you think you have a hearing loss, right? The answer of do you think you have a hearing loss is 9 times out of 10, yes. How ready do you feel for hearing aids? That's important to know, and it's important to know up front because of that motivation, right? And also, when I ask this question in clinic, I ask this before I even test hearing. I say, look, if we find a hearing loss and it looks like hearing aids would help you, how do you feel about wearing hearing aids? The answer I get back tells me a lot. And it's going to be the whole spectrum, right? Everybody from, yeah, I'm okay with that, or as long as it's not the big one, or I know they're really expensive, that's a problem, to over my dead body, And that's really going to prime me for how am I going to come back and explain these test results and talk about where we need to go next. Okay, Doc, I think I need a new hearing aid. Everybody's starting to sound like Bob Dylan. This is from Market Track Research. This is a well-known longitudinal survey and body of study within the field of audiology. And they're looking at, what are factors that make people successful with hearing aids, people that aren't successful, what are factors that play into that, how can we be better? It's a huge, absolutely massive body of data. It's very interesting to look through. One of the main themes that's come out of this is A recommendation from their physician seems to be a key motivator in going ahead. Of all the experiences that would motivate a hearing aid purchase sooner, the third most common was a positive recommendation from my doctor. So even though as a nurse or a nurse practitioner or a primary care provider, or even, if you're in other supportive healthcare roles, just saying, look, I think this would help, has a lot of power behind it. And especially if you're in a primary care role, even though you go, I don't know anything about hearing aids, just saying, look, I think this could help you. Why don't you go ahead? It actually does make a difference. So that's one of the take-home points that I want you to take from this lecture. Okay, I'm going to zoom through this pretty quickly. Candidacy, the people that are leaning towards versus the people that are leaning against. If you're leaning towards hearing aids, I say in Washington State, all hearing aids sold have a mandatory 30-day trial period. And so we talk about that, right? That you're not completely locked into this purchase and what that means. You don't know unless you try. You were worried enough that you came in today is a very common one. Better to start sooner than later. And again, that gets into some of that cascading effects of hearing loss with your relationships and kind of friction in the home with family members and stuff like that. If you're not so keen on hearing devices, watching for denial, discussing red flags to watch for, meaning if people are changing their behavior because of their hearing loss, or if they're feeling isolated, those are huge red flags. And unfortunately, people are waiting until these big red flags smack them in the face before they come talk to me. It's really sad when I get somebody coming in and they say, look, I know my hearing's been bad for years, but I went to my friend's funeral the other day and I didn't hear anything. And that's the reason they've finally come into clinic. And I say, look, we can do better than that. We can have this conversation with people earlier than that point and get them to be hearing better. Agree to meet back in at least a year to recheck hearing. This is a great tool. If somebody's like, I don't know, like hearing aids are for sissies or whatever, I say, look, let's at least recheck your hearing in a year and just see where you're at. And so you keep that touch point. Hearing aids are in your future, start saving now. Again, people that are kind of borderline, or they're going, the cost benefit at this point, like I can't just do that, or I don't want to do that. I say, at least just start saving towards hearing aids because they're going to be somewhere in your future. Okay. One of the biggest barriers to hearing aid is cost. This is the elephant in the room. I wish I could sit and give you a lot more information on this, but it's going to vary. Funding varies so much state to state that I kind of pared this back because I know we're going out to more than just Washington State here. This is the area that I assume we might have some Q&A on, and so we can kind of go there if we need to on the Q&A. But the driving factor of cost is a conversation I try to have up front because it is the elephant in the room, and it does put people at ease to kind of acknowledge that elephant. You should know that insurances pay little to nothing towards hearing aids, but they almost always cover hearing testing. So that's kind of ironic, but that's important to know. That referring for hearing testing is usually pretty safe territory, but hearing aids is the insurance is usually not the one that's going to pay for that. The one disclaimer I'll put on that is for Washington State for 2019, Medicaid, not Medicare, Medicaid has decided to start paying for adult hearing aid funding again if you have a big enough hearing loss or qualify for their candidacy. This is pretty epic. This is restoring funding that was cut in 2011. So it's been a while since we've had that. So that's been really good, actually. All right. The cost of the hearing aid is connected to the technology, not the style. So what I have on here is I've got a hearing device. This is a common behind the ear style hearing device. If I explode this out, you can see that like you've got your innards, right? And we've got like a speaker on the end of the wire and things like that. And then what this person's holding in their hand is the computer that's on board, the little computer chip that's in this hearing device. And this particular device is the Oticon Open, and they've been very transparent with like the computing speed of their device because they think it's really good, which it is. And just to give you an example, you know, that little teeny tiny computer has 8 core processors on it, or 11 core processors on it, 8 for sound and 3 for wireless connectivity or processing. And it's doing 1,200 million operations per second. I mean, it's just mind-blowing, right? So when you pay for a device, you're paying for the computer. You're not paying for like the fancy case on the outside or the look, okay? You're paying for the computer. And I always joke, and you know, people say, why are hearing aids so expensive? And I say, you're basically paying for somebody's PhD. Whoever was in the research and development department, that's where the cost is, a lot of the cost is on these devices. Okay, generic amplifiers. So the Pocket Talker Ultra, if you've not seen one of these before, they're made by Williams Sound is the company. And this is what it looks like here. This is a great tool to have in clinic, to take with you if you're working with a geriatric population, say you're doing nursing home visits or hospice, or just pretty much anywhere. And this is a pair of headphones. You can use any headphones as a standard headphone jack. You've got a microphone and you have a volume control. And these things can put out the amplification. So if I have somebody coming into clinic and they're just not hearing me, instead of me yelling, pop the headphones on them, turn up the volume, you know, to maybe 6 out of 10 and say, okay, can you hear me now? And then adjust the volume accordingly. And that way I don't have to yell and they can hear. This is a great solution for our advanced dementia Alzheimer's patients that cannot wear hearing aids because either they've never had them or they're constantly losing them and pulling them out and they just can't deal with such a small device. Also, end of life hospice, this is really good. Somebody's like, I don't want to pay, you know, $2,000 for hearing aids if I'm on hospice, but hearing's important. Folks that can't afford hearing aids, this is over the counter. You can buy it on Amazon. They run $140. They're very durable devices. You can wear them on a lanyard. You can clip them on your pocket. You can have whoever, you know, needs to talk into it, just point it to them. So I'm a big fan of this if you're needing amplification in a very generic setting or in a setting that's something nice and big that's not going to get lost or something very durable, right? So there's specific times when that's quite good to use. And then my slide for generic over-the-counter hearing level amplifiers. So these look like hearing aids, and this is a problem for people that aren't audiologists. They go, oh, it's a hearing aid. It's $50. Like, I'm gonna buy that. And I go, okay, it looks like a hearing aid, but it's not. It's a generic amplifier. And you may have seen these before. So this particular bigger model that I just popped up, you can get it at Bed Bath & Beyond for like $30, okay? It's horrible. It's a poor physical fit. It's not a custom physical fit. It's just a generic tip on the end. You can't adjust the wire or length between the part that's in your ear canal and the part that's hanging over the back. So often they're like flopping off or feeling like they're gonna fall off. Poor battery life. I know I had a patient report back to me on these rechargeable ones that you can get, that bigger picture there, that the battery life's not very good, right? So like once it won't recharge anymore, you have to buy a new unit. And so they kind of make it that way. So you keep having to buy them. That's not very good. No discrimination in amplification. A lot of people don't know that hearing devices are really sophisticated. They're monitoring the sound that comes in, and a hearing aid will say, aha, that's a soft sound, that's a medium sound, that's a loud sound. If you're a soft sound, I need to turn you up a lot so you can hear. If you're a loud sound, I don't need to turn you up that much. You're already loud. Also, it knows that's a bass pitch, that's a mid pitch, that's a treble high pitch. We need more volume in the high pitches. We don't need any volume in the bass pitches. And that type of discrimination, these generic over-the-counter stuff, they don't have that type of discrimination. It's like what comes in is what comes out. It's just all louder. And that makes for a very poor sound quality and a very kind of yucky hearing aid experience. And also no noise management technology. There are 3 main systems on pretty much all hearing aids you get through clinic that help manage background noise. And there's no hearing aid that can scrub out background noise or erase noise. We're not doing Bose noise canceling headphones, but we can identify noise and say, look, that's noise, don't make that louder. Don't amplify that. Okay, so there's no noise management technology on these. So I strongly have a beef. I recommend not spending your money on these. Save your money. Unfortunately, I do get people through clinic and they say, oh, you know, I bought this off of Amazon or I bought this over the counter. And I'm like, okay, it's trash. You know, it's just not, it's not going to work for you. Okay, so that's me off my soapbox on that. All right. What 4-letter word do folks with hearing loss use most? What? Yep, that's it. If you have hearing aids and you still have significant hearing problems, asking the right questions. When did you last have your hearing aid adjusted? A lot of people don't know that problems with hearing aids can be sorted out in clinic, and they don't even know that their hearing aids can be adjusted. And a big part of what I do in my job is I joke that I boss hearing aids around. I put them on the computer and I tell them how to act. So most hearing aid problems can be successfully addressed by audiologists. 2 essential factors for a good hearing aid experience. So what we look at when people have problems with a hearing aid, what they need for a successful hearing aid use, and again, that's that goal of what goes into success with hearing devices. We have 2 buckets here. We've got the physical fit bucket and we've got the acoustical fit bucket. So I'm just gonna run through a big old list of what falls into these 2 buckets, and you have to have both of these addressed for a successful hearing aid experience. So on the physical fit, we're looking at things like, can this patient insert and remove their hearing aid? If not, is there somebody around to help them? Retention, it's got to be able to stay on the ear, otherwise it's going to not be worn or get lost. Comfort, it's like shoes, you know, you're going to walk around and wear these all day. Are they comfortable? Or your glasses, same thing. Patient's ability to manipulate the controls. I'm not so bothered on this anymore because hearing aids have really good artificial intelligence, and I'm okay setting them up to be automatic. But it's the patient preference on if they want to do the volume up and down themselves. No matter what you do, a hearing aid's always going to be automatic in the background, whether you turn it up or down yourself. But that's a conversation we have, right? Like if somebody really wants or needs that ability, they've got to be able to actually, you know, with their dexterity, do that. So sometimes we get creative with that. So we're looking at dexterity, things like severe arthritis in the hands or lack of feeling in the fingertips can be problematic. Vision or eyesight. And I have done a few hearing aid fittings for folks that are 100% blind, and they're able to do it. You just have to describe and practice in a different modality than you would for the average person. But if somebody has poor eyesight and you're saying, look, you know, take this little battery and put it in this little device, that can be problematic. Shape and size of the ear canal can play into the physical fit of devices. If you have somebody that has a lot of earwax or cerumen, or if they have active drainage, that's important to know about if you're going to fit hearing aids. And then the memory and cognitive issues are huge. You know, is somebody going to just take these out and forget where they put them? And that I see that a lot. You know, just, oh, take these off my ears, put them here, and then never see them again. So, okay, acoustical fit. There is a very important principle when you do the sound through an amplifier, is balancing the audibility or volume against your sound quality. And that's why I have this seesaw sound sliders up here. So if I turn up the volume so it's louder so you can hear it, it's going to become more and more artificial in the sound quality. As I back the volume off, especially if somebody's never had hearing aids before, I say, look, I'm just going to lower this a little bit to kind of acclimatize you, right? To kind of step you into this volume. So as I back the volume off a little bit, they go, oh, that sounds a lot better. It sounds a lot more natural. And I say, yes, because we're getting closer to your hearing loss. That's what you're used to listening to. That's what your brain is going, okay, that's normal. So it's a very important to understand that balance, that I have to give you enough volume for audibility. Otherwise, what's the point? But I am going to balance that against sound quality. If we have a really poor sound quality, you're not going to have a good acoustical fit. You're not going to want to wear your hearing aids. Okay, so loudness and audibility versus sound quality. Noise management, I'm not going to go into that, but there are 3 main noise management technologies that are in pretty much all hearing aids. And so making sure those are working okay. And then maximum loudness. A lot of people don't know this. The hearing devices do have a ceiling where I say, look, don't make sound louder than this. Don't amplify above this level. That ceiling, I can individually manipulate the different pitches. And some people will have certain pitches, usually the higher pitches, that are more sensitive. And I need to turn down that ceiling so that the hearing aid's not being uncomfortably loud in their ear. And a lot of people don't know that that even exists as something that can be adjusted. Okay, we're on to the bonus part, and I think we're making good time. So I'm going to whip through these bonus slides on the basic care of a hearing aid, and then we'll do Q&A, and then I think that will take us up the rest of our time here. I think this is really good. Again, this is bonus content. If at some point in your life, you're probably going to have to touch a hearing aid, and so this is just some basic life skills of, you know, how to do that. First of all, the reason I have the chewed hearing aid up here, if you have dogs or cats in the home and you're a hearing aid wearer, you need to know that dogs love hearing aids. They will just chew them to bits. They're so happy with hearing aids. So if you're not wearing them, put them in the case with the lid on. Cats are a little more reserved like they are, but they do like to play with them. So I say, look, hearing aids are damaged when they're not on your ears. And if they're not on your ears, you need to put them in a case with the lid on. So your animals don't get them. If you don't have animals, the other thing that happens is they go in the pockets, right? And either your keys go in, and then when you pull your keys out, your hearing aids flip out and you never see them again. Or you put your hearing aids in your pocket and then you put your clothes in the laundry and then they're toast. So in the case with the lid on. All right, the first is right and left. So think R and R, red for right. R and R, red for right. Blue is for left. Most hearing aids are not physically colored right and left, like this pair. Usually you get a little marker. So on here, it's the very end tip that's red and blue. Sometimes the marker's on the actual behind the ear device. Unfortunately, a lot of those markers are becoming smaller and smaller. If you can't find a marker, you can figure out just by taking the behind the ear part and lining it up. You can see it's only gonna fit one way, right? When you have that behind the ear part facing you, like it's gonna hang over your ear, you can tell, is this gonna plug into the right side or into the left side? It's like shoes, they're only gonna fit one way, okay? All right, it's been lovely, but I'm turning off my hearing aids, okay? On off, you're gonna open what we call the battery drawer where the battery's at. That's literally taking the battery out of the connectors and turning the hearing aid off. So it's not a physical like toggle switch. I mean, really, really old hearing aids have those, like dinosaur old hearing aids have like a physical on and off switch. Pretty much everything you're gonna run across is gonna be open up where the battery is, open that little hatch where the battery is, and that's turning the hearing aid off. This is really important to know because if you have somebody that has a lot of volume coming out of their hearing aid and you don't turn it off, it's gonna whistle. It's just gonna screech. And so knowing that you just flick open the bottom of a hearing aid to turn it off can be very helpful. Common scenario, you have somebody that's a little bit older, maybe their hands aren't so good. They're able to get their hearing aids out if you're asking them to take them off for a procedure or whatever you're doing, but they're not good enough to turn them off. If you don't know how to turn them off, they're just gonna sit and whistle the whole time you're doing the procedure. And usually the patient isn't so aware of it because they have a hearing loss. They might not even know they're whistling, but you're gonna go crazy listening to that the whole time. So it's good to know you just flick them off, okay? Hearing aids are like a flashlight. When you're not using it, turn it off to save the battery, okay? Hearing aid batteries, if you have never run across hearing aid batteries before, they're zinc air batteries. They're designed specifically and only for hearing aids. They come in 4 sizes. You can see that each size has a color associated with it. We've got blue, that's actually brown, orange, and yellow on the Power 1 packs. And then I have them from size on the batteries that aren't in the packs are actually by size. So the largest is blue, and then orange, and then brown, and then yellow. They also have a number associated with them. So the numbers are on the very bottom right corner on the Power 1 packs. The smallest size is 10, and then the next size up is 312 and 13 and 675. It actually, now I look at this slide, really bugs me that those Power 1 packs are not in order of size. The 2 in the middle are flipped. So that might be a little bit of a fail. But the 2 in the middle, the 312 and the 13 sizes are the most common by far for hearing aid batteries. You do have to make sure you have the right size. There are the type of batteries where you peel the sticker off to start the battery. For pretty much all hearing aids, the flat side goes facing up and the battery drawer is like a little cup. So you think about like filling a cup, it's gonna be flat on the top. Also, for pretty much all hearing aids, if you get it in upside down, it's not gonna shut. So you don't ever wanna really force that. So yeah, cheapest batteries are either get a box on Amazon.com or Costco, very cheap batteries. They're about 25 cents a battery, so not a huge cost. Okay, the process of troubleshooting, if somebody comes in and this is kind of more for our rural services, because you might not always have audiology like in your clinic or hospital or down the street. And if somebody is like really desperate and their hearing aid's not working and there's nothing obviously falling off of it, try a new battery. And if that doesn't do it, make sure that it's not blocked with earwax. 9 times out of 10, it's something has clogged up with earwax and we're not hearing. And then if that doesn't do it, contact an audiologist or a hearing aid dispenser because we're trained to do deep cleaning and kind of really troubleshoot. And there are lots of parts on hearing aids we can actually swap out in clinic. It's very much my mechanic's hat to try to revive and get hearing aids working again. And there's a lot we can do in that area. Last but not least, I did give into one of my favorite weaknesses, which is hearing aid technology, and put in an iPhone slide, pairing with iPhones. And what MiFi is the shorthand for made for Apple products, if you ever hear that in the geeky tech world. And this is a really hot thing, is direct connectivity with smartphones. This is not so much my folks in their 80s and 90s, but definitely my first hearing aid wearers love this. And it's turning the hearing aids into wireless headphones for use with your phone and any audio coming from your phone, or if you're doing Apple iPad as well. So, you know, like I want to watch Netflix at night and, you know, my spouse is sleeping and I was like, just put your hearing aids in, like everybody will be happy. Anyways, if you ever need to know this, you just go into your settings, your general settings, scroll down to accessibility, scroll down to hearing aids, and then pair. That's how you set up a hearing aid with iPhone. So this is kind of a reference slide. Pretty much all major hearing aid manufacturers now pair with iPhone. There's only one manufacturer that's doing Android. They are the largest manufacturer of hearing devices. It's just a lot harder on the engineering side to build something that's compatible that way. So that's kind of interesting to watch this area. But I've had a lot of really good patient feedback about this technology that folks really like it. So that's kind of one of my indulgent slides for you on hearing aid technology. All right, I think that takes us to the end. Let's see. Yes. Whew, we made it. We have 15 minutes for questions. And start typing in. Oh, we got physical questions and digital questions. Let's do the physical question first. Okay. I'm pretty good at that. Okay.
So over the years, you can see hearing aids kind of like evolving and advancing. What do you see as like going to be the next like technological like advancement for hearing aids?
Okay, so the question is, hearing aid technology is changing all the time. What do you see as the next advancement for hearing aid technology? I think there's a few things that are always being worked on. One is miniaturization. Because nobody comes in and says, today I want the big one. The other is the speed of those computers, and that directly correlates with artificial intelligence, which is tied to management of background noise. And hearing in background noise is the holy grail of hearing and the hardest thing to do with our hearing. And that's the area that's focused on the most for research and development, is the technologies that are going to help us hear in background noise. And so I think we're going to see a lot in that area, which is encouraging because there's still a lot that there's a lot of room for progress in that area. And then with any launch of a new hearing aid product, you usually do have some kind of side benefit, which is that direct connectivity to technology of other sorts, or you know, accessory ranges or things that aren't direct ear level technology, but kind of side benefits as well. So the direct connectivity with iPhone and with smartphones has been kind of the latest big thing. Right now, it's really hot marketing on rechargeable batteries in hearing aids. And I think there's also going to be continued changes in that area, just because whenever we connect to technology more, like say through Bluetooth, it's going to eat up the battery, and those batteries are quite small. So they're looking at solutions to try to get around that. Right now, one of those solutions is, well, if you're recharging your rechargeable batteries every night, then, you know, you're not going to be miffed about having to change a throwaway battery like every 3 days instead of before, when it used to be like 7 to 10 days. So there's still a lot of hiccups in the rechargeable area from my viewpoint. For example, if something goes wrong with your gear, you're down and out all your gear, not just one part of your gear. So, you know, and some designs are coming out that are better than others. Some manufacturers will seal those batteries in, you can't get in at all. And I have an issue with that, because then my troubleshooting in clinic, my hands are tied. Others, you can do a lot, and some of them you can even change between regular batteries and rechargeable. So that's probably more information than you want to know, but yeah. And I also had somebody once tell me, if you want to know where hearing aids are going, look at where cell phones are going. And I think that's kind of an interesting thing to think about as well. Like look at kind of the general technology and which way that that's going as well. Yeah. Okay, good question. All right. Okay, I think we're ready for the digital questions.
So a great question, actually. Is all age-related hearing loss something that can be helped?
Is all age-related hearing loss something that can be helped? I think you can glean benefit from hearing aids, even if you have a tricky hearing loss. The motivation is the sticky area in that equation, and also good counseling regarding realistic expectations. Unfortunately, I think our field has a lot to do in terms of better counseling skills, and some of that's just the time you have with a patient in clinic. But being able to understand somebody's needs and set them up for success is definitely kind of a skill in that area. So I would say even though hearing aids are an aid, right, they're not a magic fix, I would like to see improvement or benefit by using them. Having said that, we're not always successful, and it usually has to do with that willingness to kind of understand and work with the limitations of hearing aids.
Okay, another question, and they can hear my questions because I'm right into my computer here.
Okay.
I've heard that a Medicare Advantage insurance can be purchased with hearing aid benefit. Are you aware of which insurance company has this feature in their plans and cost?
Wow, if I knew that, I'd be gold indeed, wouldn't I? I don't keep up with all the insurances because there's so many. I do have some general insurances that come through a lot that I have general ideas of what they usually offer. First of all, it's important to know that just straight up Medicare, not a supplement, but just straight up Medicare does not pay for hearing aids. They've never paid for hearing aids. I don't think they'll do it anytime soon just because they know eventually everybody's going to need them and they're really expensive. I think they just don't even want to touch that can of worms. For supplemental Medicare insurances, there may be ones out there that have hearing aid benefits. I do not know what they are off the top of my head or what that benefit would be. I can tell you that in the world of insurance, hearing aid benefits break down into two categories. One is we're going to give you a certain dollar amount, either per ear or just a lump sum, that is good. Like Regents Insurance, it's very common to say $800 every 3 years towards hearing aids, and it's just a dollar amount. If that's your insurance plan, that's actually quite good because you have a lot of flexibility with that, right? Like they're just giving that money over. The other option that we see in insurances is they will do a deal with a third-party provider, and they say, okay, if you want our insurance benefit for hearing aids, you need to go get your hearing aids from Miracle Ear, or you need to go through High Health Innovations or Amplifier, or some certain hearing aid chain. That's not my favorite because, again, your hands are kind of tied in the choice of product you get, and usually those products are not the best that's out there. They're adequate and they are affordable, but they're not the best. If you're struggling with those products, I say, look, go try a different hearing aid or hearing device.
So regarding the correlation of self-perception, I'm surprised at clinic visits when patients repeatedly do not wear their hearing aids. Yeah. What's the danger of their driving and engagement at the visit if they're not hearing? And do you have any outcome data on safety and time wearing hearing aids?
Oh, this is interesting. So we kind of have multiple parts to this question. I'm not so concerned about driving with hearing loss. Folks that are just congenitally deaf can drive fine and get their licenses fine. I'm more worried on the driving about things like reflexes, stuff like that. So that's not a huge concern of mine. We do get asked safety concerns like hearing fire alarms or hearing if somebody comes to the door and stuff like that. There's a whole accessory range for hearing impaired designed to address those specific issues. I think that's interesting is the other part of that question was, if somebody has a hearing loss, has hearing aids, and then doesn't use them, and so they don't wear them into their appointment, like how is that bad or affecting things, or what's the outcome of that? I think the tricky bit is people will bluff in your appointment and in conversations. And so as a provider, you're thinking, yeah, we're doing well. They get it. And then you wonder, why are they non-compliant? Or why are we going in circles? Or why are we still struggling? Or why is this person's spouse still really angry? And it could be anything. It could be medication management. It could be explaining a procedure. It could be talking about end of life planning, whatever. If that person's not hearing well, the danger is the miscommunication, where they're smiling and nodding, or you're hoping that their spouse is going to pick it up, and they just get left out. And they leave clinic confused. They're going, I don't really know, like I maybe got part of that, right? Or I maybe heard part of that. Now, the tricky bit is when we talk about people with hearing loss, we kind of lump some, like, you know, this gloss of an experience, but there's gradations of hearing loss, right? Like if somebody has a mild hearing loss and they've forgotten their hearing aids in clinic, okay, they're not going to struggle to hear because we're talking one-on-one and quiet. But if somebody has a moderately severe hearing loss and they've forgotten their hearing aids in clinic, they're not going to hear you in clinic. And there's no way for us to look at somebody and know kind of what situation they're in unless we have an audiology report. And so that can be a little tricky of you know, just because somebody has hearing aids and they forget to wear them, we don't know what level they're going to struggle with because of that. Yeah.
That's all the questions that I have. So do we have other questions in the room?
Yep.
Thank you so much.
Thank you. You're welcome.